Today, I am very, very happy to say that this session is going to be brought to us by Assistant Professor Dr. Tegan Lukacs from Johns Hopkins University in Baltimore in the USA. Dr. Lukacs is going to talk to us today about sepsis as an emergency, because that's what sepsis is. It's a medical emergency and needs immediate treatment. Dr. Tegan is a board-certified emergency medicine physician. She's practicing in the US, as I said, at Johns Hopkins Medicine in Baltimore. But Dr. Lukacs is also more. She has an MPH in global health. She has worked with like many nonprofits in sub-Saharan Africa and also on other continents. She has been working with the African Federation of Emergency Medicine in various projects, and I'm happy if you want to share some more details, Tegan, that would be nice. She's also a member of the Center for Global Emergency Care within the Johns Hopkins Department of Emergency Medicine. And this center is actually a WHO collaborating center. Dr. Tegan has worked on the WHO sepsis course and the basic critical care courses, and was also has been working in Ghana in 2023 and 2024 at the Komfo Teaching Hospital, which is a partner site in the STARS project. I'm not going to say more. I'm just going to hand over to you, Dr. Lukacs, if that's okay. I'm also going to stop sharing my screen and give you the chance to share yours. I assume that you will want to do that. And I'm happy to say we're honored to have you. Thanks for taking the time. And please, over to you.
Yeah, thank you so much. I'm really excited to be here, and I'm really excited to have this topic of sepsis as an emergency. It's one of the first topics to kick off this series. I think that it seems like a lot of the participants here today are physicians, clinicians in any sort, or researchers. And I think through doing research in this topic, it's good to have a perspective of what it's like to work on the front line and be treating these patients, individually, to understand where some of this data will probably come from. So like we said, today we're talking about sepsis as a medical emergency. A little bit more about myself. I've spent the past year living in Ghana. The opportunity I had was to work on some research focused on patients with acute infectious illnesses with Dr. Joseph Bani as my co-PI, working at our hospital in Kumasi, Ghana. The opportunity to work clinically and to do research simultaneously is, something I've definitely taken advantage of and tried to get the most out of. So I'm really excited to be here and continue this conversation with a lot of our colleagues. One of the other projects that we're working on or in collaboration with AFEM is on a emergency medicine casebook to help clinicians learn the approach to emergency cases, and also the top about 60 cases that we see in the emergency departments, with a focus on LMICs and resource-constrained practice environments. So keep a lookout for that. It's something that we're really excited is coming down the line. So today, I'd be remiss if we only talked about clinical medicine. Some of the bigger influences on patients seeking this care has nothing to do with medicine at all. So allowing us to have some space to talk about public health in our practice environment, I think is really important today too. Recognition of sepsis, timely antibiotics, fluid resuscitation are really cornerstones to the management. And then getting into some more specific emergency focused approaches to monitoring, use of ultrasound and point of care testing, and some of our EM priorities. So I'm sure all of you are here because you know this already, but sepsis has really become a big global health priority with the World Health Association's resolution for improving the prevention and diagnosis and management of sepsis, calling for the development of innovative means to diagnose and treat and novel diagnostics. And I think this is where most of you are jumping into the conversation and approaching these things from a new and context-specific way. Strategies for achieving the objectives of the WHO Sepsis Resolution, the Kampala Declaration, and the Berlin Declaration of the Global Sepsis Alliance are all things that have brought us here. As we can see in this map, I'm going to directly compare to the next slide. Sepsis really affects a disproportionate amount of the underserved world. The highest rates of sepsis mortalities are in sub-Saharan Africa. But as we see from this slide, that is a direct opposite map. Most of the research done in sepsis and on mortality, on early goal-directed therapy, is not from the location that is impacted the most. A lot of the sepsis guidelines in existence today were developed from research or have evidence backing them that were done in high-income countries with a big focus on an evaluation of those early goal-directed therapies. There's been multiple studies that have shown that the required physical equipment and personnel for execution of these early goal-directed therapies or the sepsis bundles aren't available in most African hospitals. One study showed only 1.5% of African hospitals actually had enough of the physical durable equipment to perform all of the bundle steps. So I think this is a big area of opportunity and a big area that this STAIRS project is really starting to help fill. To understand sepsis, it really depends on your perspective. To study something, you need a definition. So the process that has led to the current definition of sepsis has been long, it's been iterative, and it's been ever evolving. Currently, sepsis is defined as a life-threatening dysfunction caused by dysregulated host response, mostly to infections. This is useful to have a common language and to have a common source to collect data on. But clinically, this is something that's a little bit harder to define in our emergency setting. Most infections don't lead to sepsis, don't lead to this dysregulated host response. But being aware of it and being able to identify it is critical. So this sepsis definition is often used for research and for literature, but it's a little bit harder in practice to apply to the clinical setting. Septic shock has also gone through multiple iterations of definitions. And this is a subset of sepsis where circulatory, cellular, and metabolic abnormalities are responsible for this increased mortality, leading to this organ dysfunction and some of the more clinically obvious signs of shock that we see. As our definitions are evolving, it's hard to keep up to date, but there are a lot of opportunities for involvement with organizations like this and for updates that come out for clinical staff to stay on top of it. So one of the pillars of management in sepsis care is trying to identify sepsis. If one of our sayings in the emergency department is, if it's not on your differential diagnosis, you're not going to diagnose it. You don't think of it, it won't be part of your management process. And so really the first step is to identify patients who are potentially septic. Then the pillars of management after this timely identification include initiation of antimicrobials while aiming for source control and resuscitation with the goal of restoring tissue perfusion. And we'll get into each one of those steps as we go along here. But for context, the Surviving Sepsis campaign, kind of their first recommendation is to use a bundle. They don't say what to include in that bundle. They don't specifically say these are all the steps that have to be met, but having some way of measuring outcomes and measuring compliance or measuring your quality improvement, and just making your team, your department aware that this is something that's important, something that's being watched, and something that you can then track over time, helps to pay attention to it. If you're focusing on this and returning to this topic and returning to these numbers again and again, it's something that will become in the forefront of your mind as you're working clinically. It's something that will stay on your differential. It's something that will constantly be brought to your attention by the rest of your staff to make sure that you're not missing patients before they potentially deteriorate and develop sepsis. Part of the Surviving Sepsis campaign, one of their, I guess, biggest pushes was for these time-sensitive bundles. So here I wanted to include our 1-hour bundle, which is still being used at my hospital currently. So this is part of our daily sepsis management kind of schema or workflow. But the first thing includes measuring a lactate level. So right off the bat, that's already identified something that's maybe not available in most practice settings. After we take a lactate, we take blood cultures. Taking blood cultures before antibiotic administration is one of our kind of pillars of management, and one of the things that's measured as part of our compliance measures. After that, I think the next 2 steps are a bit more focused and have evidence across the board that shows that these are actually things that matter to patient outcomes, that actually influence patient outcomes. So our next step is administering broad spectrum antibiotics and rapid administration of IV fluids. In the 1-hour bundle from the Surviving Sepsis campaign, they're suggesting 30 mLs per kg of crystalloid for anyone who's hypertensive or who has a lactate over 4. If that doesn't help, if that bolus is not improving their blood pressure or not improving their lactate, then the next step would be to apply vasopressors. So we'll get into a little bit more of these details, but just for context, this was one of the bigger pushes and one of the protocols that really got integrated into the health system, especially in the US, that is now considered some of the pillars of management. As evidence is changing and as recommendations are changing, it's hard to kind of backtrack on some of these protocols. So this is currently still what's recommended within our hospital. But I think as savvy frontline providers, we're able to see what is most important and to prioritize for our patients. Like I said, early identification is really one of the, I think, key pillars of sepsis management. If we don't identify it, then we can't track it, we can't monitor it, we can't understand our management of it and how it's changing over time or how we're affecting outcomes. And then we can't see these downstream effects, things that we don't normally get information on from the emergency department, or patients who make it out of the ICU, patients who are having long-term sequelae of sepsis. But being able to recognize and start that time-sensitive management early in someone's care can really affect everything down the stream that happens after that. Sepsis is also something very difficult because of its non-specific symptoms. A lot of early warning scores have come to light and been studied pretty extensively to try to help physicians identify patients who are potentially, suffering from sepsis. The current Surviving Sepsis campaign recommendations are to use a score. Whatever score seems to work in your setting, whatever score seems to be most clinically relevant to you. None of them are perfect. There's the SEERS score, which is, I think, the most widely used score right now. And that's heart rate, respiratory rate, temperature, and a white blood cell count. So looking at for that leukocytosis. That being said, getting white blood cell count isn't often something that we have available to us right away in the emergency department. So understanding patients might meet two of these criteria or might not because you have an incomplete set of data. But having an abnormal vital sign can really put you at high alert that they maybe are meeting some of these criteria early on, and we just don't have all the information we need yet. I think working in the emergency department, a lot of us understand that we often have to MacGyver, make things work, make things happen for patients that may not happen otherwise, figure out how to work around things that are not coming to fruition quickly for them. So often just getting some simple information or doing some simple maneuvers can go a really long way for these patients, especially when we're seeing them in that time critical aspect in that first hour of their care. So even if you don't have a complete set of information to use one of these early warning scores, the QSOFA, the NEWS, the SEERS, having a complete set of vital signs is a fantastic baseline to start from. In terms of management, a lot of people think that this is what sepsis management looks like. You need all of these long algorithms, you need a lot of complex machinery, you need to be doing calculations and all different kinds of goals and monitoring, when really in the emergency department and in the first hour of their care, we always come back to the ABCDs. A patient who has severe pneumonia is coughing on their secretions and has an airway obstruction from a mucus plugging. That's bread and butter emergency medicine, right? Airways first. So addressing any life-threatening conditions that the patient may come in with is really always our number one priority. For the non-emergency trained physicians in the room or researchers, airway is the first step, right? We always make sure that the airway is patent. Breathing and listening to breath sounds can go a long way in discovering any emergencies. Sometimes patients come in with infections that have caused them to have other problems, fainting, collapse, car accidents, you name it. And, patients aren't always so straightforward to come in and say, oh, I've been coughing and I have a fever. Of course I have pneumonia. Looking at the circulation of a patient can give a lot of information on critical life-threatening disease processes, but also this is going to play a lot into our management in the next couple of steps of what you're going to do in terms of septic shock. Disability, level of consciousness, patients who are completely unconscious, then you need to circle back to your airway breathing circulation and see if that lower GCS is something you need to intervene on right away. And then looking at environment, signs of injury, but also cellulitis and skin infections tends to be one of the more missed diagnoses when patients come in and are showing clear signs of sepsis and some kind of a severe disease process without another obvious cause. So getting into the mainstays of treatment, timely and appropriate antibiotics is one of the most proven aspects of sepsis care. And there's a lot of controversy around what kinds of monitoring to do, what kind of fluids to use, how much, but timely and appropriate antibiotics is something that has repeatedly shown to improve mortality in every setting. But what do we mean by that? What do we mean by timely and appropriate? According to the Surviving Sepsis campaign, timely means within 1 hour. But we don't always have all the information we need within that first hour. So some of the recommendations have come to realize that and allow for that. In the ED, sometimes these early warning scores can be falsely positive for patients who don't have infections or don't have this severe response to infections. If you if I run a lap around the block that I lived in Ghana in the hot sun, I would meet sepsis criteria. I would meet SEERS. I would have elevated temperature, elevated heart rate. So not every positive Sears criteria or positive early warning score means that the patient has an infection for sure. So this is our way of allowing for us to investigate that. Within the first 3 hours, we should be expediting that investigation if the patient's not septic or not in shock, right? If they have vital signs that are compensating and they're not completely fluidly in shock, their mental status is not completely depressed, then we have time to draw cultures. We have time to do some additional testing to see if we can't focus where that antibiotic or antimicrobial therapy should be more focused. If a patient's in shock, if a patient is showing signs of severe sepsis, empiric therapy should be started as soon as possible. This should be based on the patient's symptoms. If they're coming in with a cough and a fever, we're going to assume it's a pneumonia and start empiric therapy as soon as possible. But this should also be based off of local epidemiology. And on that note, also resistance patterns. As antibiotics are more and more available to different populations, we're increasing that availability of therapy, but with that also comes inappropriate use and fear of developing resistance to certain antibiotics. So following local epidemiology and local resistance patterns is really important when focusing on the empiric therapy. Once a more specific diagnosis can be made, then therapy can be focused. If culture results are available, if there's sensitivities available, then the therapy can be tailored to that specific individual. Fluid resuscitation is the second pillar. The management with IV fluids is essential to restore blood pressure and ensure adequate tissue perfusion. This is a emergency medicine kind of pillar, right? We're managing the patient when they hit the door. If they don't have signs that they're fluid overloaded, IV fluids are the appropriate first step for sepsis management. Not getting into too much microbiology or too much pathophysiology, the issues that we see in the vasculature are microhemodynamic problems from sepsis. There's that increased vascular permeability, decreased tone. This is a distributive shock. But in the emergency department, we primarily measure macrohemodynamic factors. The ability to measure and get information about these minute changes in the vascular schema are really difficult and aren't available within the first hour anywhere that I'm aware of. So looking at the macrodynamics, measuring patients' cardiac output, measuring their blood pressure, measuring these more readily available signs of their fluid status is typically where we are in the ED in the first hour for sure, but I know patients are not in the ED for only an hour. So making sure that we're monitoring these things over time is kind of the critical aspect into this. What we really worry about in this section is that past that hour of fluid resuscitation is that we run into lots of the dangers of over-resuscitation. Currently, our practice in the US is to evaluate the patients individually and see if they have risk factors for fluid overload, if they have congestive heart failure or renal failure, and to just write in our chart to justify why we're not giving that 30 cc per kilogram bolus, why we think that they should be managed with smaller aliquots. The Surviving or the World Sepsis Campaign just this past week had an entire session 4 that was focused on the dangers of fluid overload, on the dangers of over-resuscitation and giving too much fluids, and on fluid choice, on how to monitor and manage patients. I think as a general precautionary rule, it's best to start small and continue monitoring and making sure that we're tailoring the fluid management to individual hemodynamic markers that I'll talk about in a minute. So the next step in emergency management, when patients come in, right, we draw blood cultures right away, we get fluids started, we get antibiotics started. But the next step in their emergent management is to figure out where this is coming from. You know, what's actually causing the patient to deteriorate? What's causing them to have this irregulated response? Where is the infection? A detailed history and physical exam, I'm sure I don't have to tell you, is the mainstay. And the more questions you ask, the less tests you have to ask. The physical exam can really go a long way in terms of empiric diagnosis and coming up with your leading diagnosis. But pneumonia and urinary tract infections are still the leading cause of infections. So a chest x-ray and a urine analysis are kind of baseline on everyone who comes in and doesn't have an obvious source immediately. Patients who don't have obvious sources on those even might need some additional imaging. CT imaging or lumbar puncture, depending on what their clinical status is like. But empiric antibiotics or antimicrobials should not be delayed while this is happening. If the patient's actually in septic shock or look very sick, and I think most clinicians are pretty good by the time they're done with school to figure out sick or not sick. If a patient looks really sick, you're going to start your antibiotics as soon as you can. You know, if that has to be empiric, that's fine. You can tailor them later once you have some of the might not happen in the first 3 hours. You know, getting a CT scan is definitely not something that happens in the first hour or two when a patient hits the door in emergency department at Confe Noche. So understanding your practice limitations and making sure the patient's safe while we're getting more information is really important. But source identification is also important if we need to do something about that source. If there's signs of abscess, there's signs of severe skin infection that needs debridement or surgical resection. If they have appendicitis, if they have a biliary disease, you know, if they need a surgical intervention, if it's an OB-related infection, you need to get some additional specialists involved to address this main source of infection. You know, sometimes antibiotics aren't enough. They're a good first step and definitely should not be delayed. But sometimes you need to remove devices. You need to remove indwelling catheters, hemodialysis ports, or drain an empyema. So understanding and identifying that source to make sure that we're not missing something that needs to be addressed is important as well.